Good afternoon, everyone. Welcome and thank you for joining us today. Just a couple of quick announcements before we get started. This seminar is being recorded and the recording will be posted on our website by the end of the week. CHESS or MCHESS continuing education credits are available for attending the webinar today, and details on how to receive credits will be emailed after the event. All participant microphones are muted, so if you have any questions or comments during the seminar, please enter them into the Q&A box or the chat box in your WebEx panel, as there will be time for questions towards the end of the event. I'll now hand it over to Dr. Maria Fernandez to welcome us today. Thank you.
Thank you, Ricky, and welcome everybody for the fourth in our webinar series from the Texas Institute for Implementation Science. This was our inaugural webinar and workshop series that hopefully we will be doing annually. And this is our last for this session. We started it off with a kickoff by Dr. Balasubramanian and myself, followed by Abe Wandersman and then Jeffrey Curran. I'm going to turn it over to Dr. Balasubramanian in a minute to introduce our speaker for today. We also have been working with a group of very talented individuals wanting to get more experience and working on their own research projects in dissemination and implementation research over this semester, and hope to do the same next year. And you should be looking for advertisements for applications for that workshop in the beginning of next summer. So thanks again for participating, and I'll turn it over to you, Bijal.
Thanks, Maria. So it is my pleasure, my honor to introduce Dr. J.D. Smith for our talk today. Dr. Smith is Associate Professor in the Department of Population Health Sciences at the University of Utah School of Medicine. He's an implementation science methodologist and clinical health psychologist. He's a fellow of the Implementation Research Institute and on the training faculty of the NIH Training Institute in Dissemination and Implementation Research in Health, as well as 2 NIAID-funded programs for implementation research in the field of HIV. Prior to joining the University of Utah in the fall of 2020, just recently, Dr. Smith was Associate Professor in the Feinberg School of Medicine at Northwestern University in Chicago, where he served as co-director of the program in Dissemination and Implementation Science, and as Associate Director of the NIDA-funded Center for Prevention, Implementation Methodology for Drug Abuse and HIV from 2015 to 2020. He has served on a number of expert panels for the National Institutes of Health on implementation science to reduce health disparities and improve outcomes in HIV and cardiovascular health for children and for adults. Dr. Smith is also Associate Editor of the journals Prevention Science and Family Systems and Health, and a consulting editor for implementation research and practice. So as you can see, Dr. Smith brings extensive experience in implementation science research, and I'm really looking forward to hearing your talk on rigorous implementation research, the implementation research logic model, and key design considerations. Thank you so much, and without further ado, I'll let you take it over from here, JD.
Thanks, Bijal. Really appreciate that. I did the cardinal sin of trying to squeeze in too many slides to the time allotted for this talk. So there will be a few that relatively quickly, but the slide deck will be made available for folks. And a lot of what I'll be discussing today is actually in public, so more information is pretty easily found. So implementation research with a focus on using the implementation research logic model, which is a recently published paper in implementation science that I led with a couple. And we'll also be talking a lot about some key design considerations for implementation research projects, with a bit of an emphasis on more experimental, quasi-experimental, and randomized designs that are possibly more useful implementation preparation and formative pilot study phase. Colleagues who were instrumental in helping us develop the implementation research model, and also folks who I've worked really closely with around implementation research designs, as well as a number of implementation research grants that I've either led or been the lead implementation researcher for. Today, I'm going to talk a little bit about kind of also posing implementation research questions, which really how we would actually design tests of implementation research questions. We're going to cover the three big buckets of within design, between site designs. And I'll cover some kind of key design considerations that may differ a little bit from more traditional clinical trials and other kinds of research. Also give a little bit of guidance, I hope, on how to select the appropriate design given research questions, as well as some of the contextual factors and other considerations have to deal with in real-world research like implementation research is. And then I'll end today with an introduction to the implementation research logic model, discussing the executing, recording, and synthesizing implementation research projects, and discuss a little bit the principles and resources available for use of the implementation research logic model. About that, so I think you guys know this, but I wanted to emphasize what is implementation science trying to do, and this is a slide that I got from he also published in Implementation Science Communications. We have an intervention, a practice, or an innovation that we might call the thing. Effective, the thing actually works, typically to symptomatology, functioning, and other things kind of at the patient level, what we might consider to be the clinical outcomes or program outcomes. Dissemination and implementation research looks best at how to help people and places do the thing. So what we do to help them are called implementation strategies. Implementation strategies are the core of implementation research. Kind of pieces related to implementation strategies within designs, as well as the implementation research logic model as we go through. And the way that we understand the effects of those implementation strategies is implementation outcomes, which are quite different from clinical outcomes. How much and how well people actually do the thing based on the implementation strategy supports that we provide to them. Review, but I wanted to also talk about kind of the difference in the emphasis in effectiveness versus implementation research. So within effectiveness research, the intervention itself is at the forefront. So this is our clinical intervention. And because it's at the forefront, we are most interested in evaluating and demonstrating an effect on health outcomes for patients or for participants, depending on what kind of an intervention it is. In the background of all effectiveness research is a system to support adoption and delivery of that intervention with fidelity. Oftentimes, this is not really discussed, really not the primary focus of that kind of research. When we move to implementation research, we kind of flip the script, or we flip the foreground and background, where the intervention typically kind of recedes into the background. We've already established that it's efficacious as well as effective. And now what we're focused on is really that system that's that we really need to rely on to support that intervention with fidelity. Without delivering with fidelity and without having a good degree of adoption within to have a population level effect. And because we are focused more on the system, we focus on strategies and implementation outcomes within this kind of research.
JD, I'm sorry to interrupt you. We're having a little problem with the audio. It's cutting out a little, so maybe just get a little bit closer, perhaps.
That I can also try to put in headphones, and that might actually help a little bit as well. So let me try that.
Sounds okay now.
Okay. Let's see if this actually works. I don't know if the headphones are going to make any difference or if they're probably not helpful, actually. Okay. So I'll just stay close. So some common implementation research aims, these are very general. We are often kind of aiming to understand the barrier implementation within a particular context. Be primary care, public health setting, community-based organization, tools, things like that. We might also be interested in what we need to do to adapt an evidence-based intervention for a specific. We may also aim to evaluate the impact of an adapted evidence-based intervention, to select, develop, or adapt implementation strategies to support an EBI, with feasibility or specific strategies, which is often done kind of as preliminary for a larger study. And then we also look at the evaluation of the or of implementation strategies, which we often refer to as a comparative implementation or sometimes a head-to-head implementation trial. As you can imagine, this is a little bit of a hierarchy, or at least kind of a continuum. We discussed this in the cited AIDS paper, which really kind of talks about towards more stringent and rigorous designs that are needed to address each of these aims. Today are designs that are used to do aims 6 and 7, the strategies. So some implementation research questions that you might ask. We often derive the questions from the research practice gap. And that gap can be really quite different depending on the type of intervention and the service delivery context. But there should be a clear link between a research to practice gap and an implementation research question. So using some examples from the world of HIV prevention, some implementation research questions you might ask are, is delivery of pre-exposure prophylaxis more effective when it's provided within the clinic versus referring to a specialty PrEP provider outside the clinic? Under what conditions does implementation strategy A work better or efficiently than strategy B for getting patients on PrEP and maintaining adherence over time? And what contextual barriers are related to low adoption of new intervention X in Y setting? And you can kind of fill in the blanks there with something pertinent to your area. Just a little bit further, I want to provide a little example implementation research study that builds off this PrEP example. So just as the premise, we're thinking about a large healthcare system with 54 primary healthcare clinics that are operating within a high HIV prevalence urban area that wants to increase PrEP uptake of their patients, eligible patients, by 50%. So this is a bit of kind of a QI kind of premise, but we can use implementation research methods to test this. So we compare whether referring potentially eligible patients to a specialty HIV clinic for PrEP in their clinics would result in better outcomes. So this is what also implements. The health system has partnered with an implementation scientist to devise a study to test this. So here's the research question that could be proposed. Does training primary care physicians to identify and prescribe PrEP as part of preventive care, better adoption, and to patients compared to referring them to specialty?
JD, I'm sorry to interrupt you again. Sorry to interrupt you. We're still having problems with your audio. I don't know if maybe turning off your webcam might work. Not sure. It's just skipping.
I'm also at my mom's and can't vouch for the quality of the internet. But this might be helpful. Okay, let me know if this is still challenging.
Sounds good so far.
Okay. A few different things. Let's understand the components of an implementation study. Training, as well as identifying and prescribing PrEP as part of routine care are our two implementation strategies that we're interested in evaluating. So these are what we might consider educational strategies and restructuring strategies. Of PrEP for those within the clinics. And we are also looking at the degree of reach that we have to eligible patients within our healthcare system. And we can define reach if that's something that needs to be defined, but I think you guys have already had some exposure to some of these implementation outcomes. So there are other implementation interests. Some might be acceptability and appropriateness for the particular setting. Which would get into some of the issues that surround stigma and other issues in HIV care and pre-exposure prophylaxis. I won't get into that too much. Another thing that we can look at is, just from our research question, is that it lends itself to a comparison-based trial design. We have two different conditions. We have a prescribing PrEP as part of routine care, and specialty STI HIV clinic, which would look at basically a comparative implementation trial. So these are not very good specific aims, but I wanted to provide them just in case. So our aims might be to train primary care providers to identify and prescribe PrEP as part of routine preventive care, increase their adoption of PrEP screening, and identify the most effective practice for reaching PrEP eligible patients. And again, this is our comparative implementation aim within this study. So just that kind of leads us into a number of different options, and some of these are more or less relevant to the example, but I'm going to go through a bunch of different designs for implementation research that I hope would be at least spark some ideas for your own research areas. And again, we'll be covering with between site, non-experimental, quasi-experimental, randomized, and non-randomized variants of each of these different designs. So in terms of the terminology, when I use the word design, it's referring to a planned set of procedures to do a number of things. So to select the subjects or larger units of the study, to assign these subjects or units to different conditions and their naturally chosen conditions, and I'll give an example of when that might have happened and when you might actually either want that or need to go with a naturally chosen condition. Lends itself to procedures to assess and measure before, during, and after the assignment and the conduct of the study. So kind of a disclaimer before we really note and kind of hit this hard that community and the different organizations that participate in our research need to be involved in the design decisions and also need to have ownership over the design. And when we say ownership, that actually means having the ability to influence, change the design, and to potentially stop the study if certain things are either met or not met. And that should be part of any implementation research protocol. In a paper that I was co-author of in circulation research, we talked about how there's really a legal, moral, and ethical responsibility to involve organizations and the community in the design decisions. And you can see here some of the key areas where we might involve stakeholders and leaders within the community and the healthcare organizations that we work with. Kind of thinking about that continuum of moving kind of from the less experimental to the potentially more experimental, rigorous designs. One of the areas that I wanted to kind of point out is that a lot of research that we do falls under kind of an implementation preparation stage. So we define this as research that is in preparation for formal evaluation or test, but typically doesn't actually involve a fully powered randomized design that you might expect for later stages of implementation research. One of the things that we might be trying to accomplish within kind of an implementation preparation phase of research is to understand implementation processes and barriers facilitators, so we can understand how, what we would need to do to change it, or what kinds of strategies would be necessary. You might start this time to explore the feasibility and acceptability of novel implementation strategies. So let's say you're trying to restructure and change a clinical workflow within a setting. You'd want to know for sure whether that was actually possible and whether people in that setting were actually acceptable to that idea before proposing it in a large study. Otherwise, we also use this time to develop or to tailor novel implementation strategies for specific contexts and be able to then specify them for. There's also a preliminary step often of adapting evidence-based interventions, and adaptation is itself an implementation strategy. And so sometimes there is a process, usually a pilot process or a community-based participatory process for how to adapt evidence-based interventions. We also can conduct simulation modeling during this time, which really has the potential to inform implementation research. There's more and more examples of this hitting the literature, but kind of is an underused methodologic resource for implementation science that can be very helpful, particularly for large-scale implementation, where even doing a pilot would not be feasible due to cost or to disruption to a large number of people and organizations. So some common methods that are used during implementation preparation are doing things like field studies, doing observational studies, community-based participatory research, There's a particular method called dynamic systems modeling, and actually there's a workshop on that at the D&I conference here in about 2 weeks. People do a lot of surveys and mixed methods kinds of analyses, key stakeholder interviews, focus groups. You could even do a small pilot. Small pilots are often at a later stage. So when we think about any kind of implementation research trials, there's a number of kind of characteristics as well as caveats and challenges that we want to think about just kind of in general as we're trying to design an appropriate study. In many situations, external validity is valued more than internal validity in terms of the a causal relationship for the particular, but even sometimes for the implementation strategies. And one of the ways that this plays out, in a lot of studies is whether or not the implementation strategies could actually have uptake outside of the implementation research study that is being funded. So that goes into the external validity. In many situations, though, you do want to have a balance of internal versus external. So being able to establish a causal relationship that shows that an implementation strategy is more effective in some comparison condition. But there's always a consideration for whether or not that finding and whether the design is actually externally valid as well. So probably more so than other kinds of clinical research. One of the principles that we like to kind of in our design is that any design should minimize disruptions to and burdens on the system. This goes directly to external validity and feasibility, but also it's one of those things that potentially could sink a study if the proposed design and implementation strategies are too burdensome. And is that randomization, but not all, occurs at higher levels of the service delivery system. And what I mean by that is not the patient. So that's in direct contrast to most clinical trials where it's patient level randomization. And interested in the higher level units such as the provider or the clinician, the clinic itself, potentially clinical teams within clinics, and you can also go up to higher levels of like counties and even country as unit of randomization, which has been done by the World Bank as well as what this often results in is that you have a small number of units, or at least a smaller number to be used to in clinical research. There's also necessarily going to be nesting within multiple levels of the system. So you'll always have patients nested within whatever higher level you have. But even if you're randomizing at the clinic level, that clinic could be part of a large, it's also part of a community that may have some influence on whether or not the implementation works. Many interactions between these levels that must be considered in any trial design and an analytic plan. In the case of experimental designs, in most strategy or strategies that are being, they are manipulated by someone within the research team or by the different units that are assigned to that condition, which serves as the independent variable that having exposure to a clinical intervention or not, you have exposure or use of certain implementation strategies or not. So let's actually dig into the three different kinds of designs. And this is borrowed from a close collaborator of mine, Hendrix Brown, and his colleagues who published this paper in 2017. That is kind of taxonomy, I guess, of implementation research designs. So they laid out which are really used to evaluate change within a single site or a single unit. Between site designs, which is exactly what it sounds like, comparing outcomes between two or more sites, usually that have different conditions. And then you also have within and between site designs where sites begin as one implementation and move to another. I think this is designs like stepped wedge and rollout designs that I'll go into a little bit of detail here in a second. Designs and some of their definitions. So within site designs, there's three kind of primary types. There's a post design, where you only measure implementation outcomes and outputs after a new evidence-based program is adopted and implementation strategy to support its delivery. And type of design and quality improvement, particularly when there's no baseline data available because the program did not exist or the intervention did not exist prior to doing the post-design study. More common, I think, that people will be very familiar with is pre-post design, where implementation outputs before and after a new implementation strategy is used or a new evidence-based program is delivered or adopted within a setting. This is also common within quality improvement to see if they can improve implementation outcomes, but can be used in other contexts as well. Another kind of design that's used for within site evaluation is interrupted time series. So this is typically single unit experiments, often with multiple internal validity and ability to say that there was a causal relationship. The single site studies within time series can demonstrate feasibility and initial impact, but you really do need multiple sites for a full evaluation because of variation and potentially confounding variables that really are only solved for replication across multiple. So these types of designs are rarely randomized, but it is possible when you have multiple larger units. There's some examples of that if anybody's interested. These are simple and useful designs, and they often get used for pilot studies and phase. They move on to a larger, fully powered trial. These kinds of designs are best for aim is really to establish local knowledge, meaning understanding what works for you in a particular setting, but maybe is not particularly generalizable, and also for answering QI type questions, as I already mentioned. So between site designs, there's a couple of different ways. The probably most common way is that you have a novel implementation strategy that you're introducing versus a routine practice, or what's often called kind of implementation as usual. These can either be randomized or non-randomized, and there are situations where randomization just isn't possible, and so either randomization or a quasi-randomized design can be used. But the most powerful is to randomize a number of different sites to either get the novel strategy or to continue with implementation as usual. Common between site design is what I mentioned before, the head-to-head or trial design. What we are doing strategies for the same clinical or preventive intervention, and there's within that Hendricks-Brown paper, there's basically 7 different kinds of evidence-based interventions that you could use. Things like programs, practices, policies, etc. Within this kind of design, and actually this is true for both the novel strategy and the head-to-head, we strive for equipoise, and so the 2 different conditions really need to have equipoise, and randomization can increase internal validity of these designs to really be able to say that there was a causal relationship, or definitively that one condition is better than the other. Couple examples of these designs. So this is a non-randomized implementation design comparing a novel implementation strategy versus routine practice, where you had 2 groups, again, not randomly assigned, but maybe they trial, or maybe these were naturally occurring conditions, where again, we go back to our example from PrEP that we are referring for pre-exposure prophylaxis. In group A, strategy is where we are introducing an external partnership with a specialty PrEP provider to be able to provide PrEP. In group B, there is no partnership with the PrEP provider, and therefore group B has to figure out how to either provide PrEP itself, or there's no model there for comparison. And again, you could determine which groups are who gets allocated to which group through self-selection or a readiness criteria, potentially selected invitation, or issuing a RFA or a RFP to then determine who should be eligible for which one. There's a high chance due to the capacity and readiness issues that are often involved in this kind of a study design, and that's part of the issue of it being non-randomized. Comparative implementation trial. This is a clinic level randomization where you might have a whole bunch of eligible and willing STD clinics who then get randomized to 2 different implementation strategy conditions. So again, we have the integration of the prep provider within the clinic, or we have the referral to an external prep using a partnership model or partnership approach. In both situations, there is a prep delivery system, so that should be held relatively constant. And the clinical intervention is the same for sure in both arms as prep uptake and adherence. And the reason that this has to be the same is that, really we're trying to isolate the effect of the implementation strategy, not of the intervention itself, or not of the clinical intervention itself. A slight variant on this, and I will just kind of click through because my animations aren't great. This is a within clinic family level randomization. This is a trial that I'm a principal investigator of that we recently completed. This is a childhood obesity prevention program. Had 3 clinics that were not randomly assigned. This was self-selection. So clinics that provided integrated care within their clinic, and then 3 clinics who referred patients to a service provider outside of their clinic. So that was our 2 implementations. Families were randomized to either get service as usual or to get integrated delivery or the referral to the family checkup for health program. So family is the actual clinical intervention. Families or both conditions randomized families into the service delivery system. Of course, because the strategies are vastly different, there is a slightly different delivery system to get people to family checkup for health. An example where you can do individual level randomized assignment, but it's within a non-randomized comparison condition of 2 strategies. Another class for comparison are and most designs. So this is kind of a general class of optimization designs. So the SMART design is what's the acronym stands for Sequential Multiple Assignment Randomized Trial. The goal is to optimize the dynamic and so in this situation, you have to have at least and preferably 3 different strategies for the different conditions that sites get randomized to. And I'll show you an example here in 1 second. SMART designs allow implementation strategies to be evaluated while responding to clear to achieve impact, which is one of the benefits, is that low performing clinics actually get a boost in implementation strategies. You adapt the strategy to address the differential response, and randomization is obviously required, and actually it happens twice within a SMART trial. So here's an example of our STD thing. So we had willing and ready STD clinics who are randomized to 1 of 2 implementation strategies to start. One of them is the impact, the other one is the referral to prep. If we just follow the upper path here for those randomized, at this point, there's what's called a response mechanism. And you evaluate whether or not there is high uptake or low uptake, and basically stratify or have a benchmark that has to be met to be considered high versus low. Those who are high, meaning they're responding to the implementation strategy, simply continue. Those who are low get to the alternative implementation strategy condition that you see here, or to an adjunctive strategy. So in this case, additional provider training. And essentially, the other path is just a referral to prep that happens first. If there's high-low uptake, there's continuation for high. And need remediation, they get re-randomized to either the other primary strategy or to the adjunctive provider training strategy. And in between site design, rollout designs for implementation research. So one of the examples is a stepped wedge. That's probably very familiar to folks. Other terms are dynamic waitlist design, as well as just randomized rollout design, kind of capture the majority of it. All of these different kinds of designs, regardless of which one you use, assign units randomly to when and what is used. And I'll show an example here in a second. There's a number of benefits to rollout designs, one of which is in delivering new implementation strategies across multiple. If you had a centralized practice facilitation group and we're trying to basically scale out a practice across 120 individual practices, which actually is a study that I'm involved in, it would be very difficult to have enough practice facilitators to do 120 clinics. So we roll them out in batch in a second. There's a lot of equity involved, as there's benefits for starting earlier in the sequence and to starting later. You can probably figure out what those are. This is also a very beneficial design to statistical power because we use within and between site comparisons simultaneously to increase the amount of data that is available. Here's a randomized stepped wedge implementation trial design. In this particular example, we have a comparison of two strategies. So it's a cluster randomized that involves 20 STD clinics. So in each cohort, 4 clinics, 2 of which get assigned to one condition, the other 2 get assigned to another condition, evaluating the baseline, and then we have the intervention data for a crossover point. So the reason that this kind of design is called a stepped wedge is we have a series of steps which indicate the actual crossover from one condition to another. In this case, it's implementation as usual to implementation strategy support. And then we also have wedges of data. So we have these upper and lower wedges that we can compare. And at any point in time, we have within site comparison. So we can look at pre and post implementation effects for just this cohort or any of the others. And we also have at any given point the ability to do between site comparison across the different cohorts. And by combining all the data, as I mentioned, we increase our power. Implementation trial design that is a modified stepped wedge. So as you can see, it does not have the full wedges like we saw in the other design. It's a complete wedge design. This is actually a trial that we're doing for cancer symptom management, where we have 7 different clinical clusters. They're all clinical oncology units within a single healthcare system. And we are going to evaluate them about a year before they roll over into the implementation period, and then for about a year and a half after they begin the implementation. So choosing a design, one of the questions to ask yourself is what design type is required to answer your implementation research question? Some of the things to consider are at what level in the system the primary outcome is being measured. The primary outcome should be aligned at the same level as the implementation strategy that's being targeted. A really easy example of this is if you're trying to increase fidelity of delivery of an evidence-based behavioral intervention, and your implementation strategy should then obviously target providers, because it's provider level fidelity that we might be interested in that kind of a situation. So a strategy that you might use would be training, as well as audit and feedback of fidelity to specific providers. Therefore, you have all the same level of both implementation strategy and primary. Another question is, do you have sufficient units to answer your implementation research question? And as we kind of, especially of the more advanced designs, you may need a lot of units to do that, and it may not be possible in every situation. The other question is the units, and this is both a logistical question. Sometimes there are implementations that make it really difficult to actually randomize units to them because they're interconnected in ways that we can't disentangle, and so we can't treat a common EHR system that can't be turned off, and we're using an HIT-based implementation strategy. It also might be that the community partners and organizations that we were working with are not willing to be randomized. They would like to, as usual, if they're in a rollout condition, and therefore you may not be able to randomize, and a non-randomized design would be needed. A related question is implementation as usual acceptable? And if not, you may need to consider where everyone would eventually get the implementation, or a comparative implementation design, or a most smart design in both situations where everyone gets to be involved in the implementation of the new intervention. So some fundamental challenges, I'll go through this kind of quick. You really need to develop a strong design that satisfies the needs and obligations of all key stakeholders. And this really requires building and maintaining partnerships with lots of different groups that would be in intervention. Oftentimes I see, especially with kind of new, that they think that the only partnership that's needed is the academic and service delivery partnership, when in fact, there are often a lot of people in the kind of next level within the community or adjunct health services, other folks that really need to be involved in order to make this actually go And so having a larger network of partnerships is often necessary. Achieving sufficient statistical power is somewhat challenging in these trials, the nested nature and to the small number of units. To do or find better ways to balance, randomize, and analyze such implementation trials, but those kinds of methods are put out pretty. We also need a little bit of direction on how to conduct it. Currently, there's not really any well-established and agreed-upon best practices for things like discontinuation rules, randomization rules. Things. I know you had a from Jeff Curran, so I'm going to act I think it's simply into the implementation research logic model. IRLM is a tool for increasing rigor and reproducibility of implementation research. And as I mentioned, this is a recently published paper that came out just a couple of months ago in implementation science. Lots of available resources within that paper, and I'll mention a few here. So we took logic model really. One of the key challenges that I think a lot of people, especially early, but it's still a challenge even for folks who are more seasoned in implementation research, is how to integrate all the necessary components of implementation research, which often involves multiple models, frameworks, and theories, into a single cohesive and rigorous design. A really big push in science in general, but also within implementation research for better transparency, rigor, openness, specification, and reproducibility of the research that we conduct. And we felt that a logic model would be a great way to start that. You guys all know what these mean. We felt that also that improving this in implementation research would be necessary to inform our understanding of how implementation strategies work for conditions work, and also on what implementation and clinical outcomes. So this is really kind of a way towards understanding the mechanisms of action and some of the ways that at this time. The other thing that we wanted to incorporate within our logic model was a testable way of explaining the phenomenon by specifying the relationships among the variables, which would allow. This is really a causal pathway modeling approach, which I think in the model itself when you see it. So there's a generalized theory that kind of guides the implementation of research logic model. We specify three kind of core components: implementation strategy and evidence-based program that are related to the implementation determinants, meaning that there is a kind of interaction between the context-specific barriers and facilitators, as well as the evidence-based program, that help us determine what strategies we use. These strategies work through specific mechanisms of action to change the context or the behaviors of those within the context to implement the evidence-based intervention. And do that and assume here that implementation outcomes are the proximal impacts of the strategy and its mechanisms, which then relate to the downstream clinical outcomes of the evidence-based practice. So the IRLM is meant to aid in the specification of the relationship between these foundational elements, and really, again, in this causal pathway kind of a perspective, we have a direct line or a path analysis, essentially, the determinants of action that determine whether or not we have outcomes. So I'm going to show some formats of the implementation research logic model that incorporate that generalized theory with some of the implementation study designs that I already covered. So again, we start with the implementation determinants. And here you'll notice these are the consolidated framework for implementation research categories. We then pick our implementation strategies that are conceptually related to those determinants. We hypothesize the mechanisms through which those strategies the barriers, and would specify the proximal implementation outcomes that occur in service and clinical patient outcomes that result from proper and appropriate implementation. You might recognize too that this is Enola Proctor and colleagues' implementation outcomes framework, where they have posited strategies basically predicting outcomes and clinical outcomes. So there's a number of variants of the implementation research logic model. One that we propose is when you have a situation of comparative implementation, that you might actually specify very clearly within the logic model the two different implementation strategy conditions and what strategies are involved. Otherwise, the model stays. Another special case is that you have multi-context implementation intervention. So you can have context one, context two. A study that I lead is delivering an intervention, split actually, intervention across faith-based communities and churches with community context-based determinants for each of those two different delivery systems, as well as different strategies that are involved in the delivery of the intervention for context one and context two. We talked a little bit about smart designs, but in general, you could also kind of specify the different kinds of optimization trial, which I didn't talk about, but smart trials are one example of an optimization trial. So in this example, we have 4 clusters in one setting where you have 4 different implementation strategy packages that you're testing against one another. This could be a randomized design that I've written about before, but either way, you specify exactly what strategies are being different conditions. One thing that we did basically through consultation with different community partners and other researchers is we learned that people often like to have the clinical intervention specified within the logic model. So we also have a variant that shows where the clinical intervention is, which can be really helpful in understanding why certain implementation strategies were chosen, and potentially even why the intervention was chosen, given the determinants, which is kind of depicted here with this, this arrow showing that the determinants within the setting also influence conceptually. We also had another variant that had mechanisms because this group mechanisms were separate from the strategy mechanisms. I should mention that all of these different variants of the IRLM are available in the manuscript and the published paper, as well as on a website that I'll give you a link to here in a moment. So in terms of research logic model, we have a principles-driven approach that is 3 key principles. So we want to strive for comprehensiveness. So that's listing all determinants, all strategies used, even if those strategies are already present, not being introduced or manipulated. We still want to know what, and then obviously all of the implementation outcomes that are being measured or are relevant. Principles indicate the key conceptual relations between the elements in alignment with a specific theory of change, and I'll show an example in a second. And then principle 3 is to specify critical study design elements, which some of those variants of the implementation logic model can be helpful for, but you can also simply note the primary outcomes at different levels, the strategies in the experimental conditions that are present, and then again, use the different formats. So here's an example of a completed hypothetical IRLM. This is a obesity management centers. So we have the specification of this behavioral obesity box. Then in this particular case, specified all of the outcomes that we hoped to achieve. And you can see in there's a primary. We then specified all of our centers that would be useful to understand for this behavioral obesity management program's implementation. And we also, I'll show you in a second too, what that notation means. We also specified implementation strategy using to implement this program, and we hypothesized a number of mechanisms of action. So a couple things to highlight here that shows the use. We actually rated or noted here whether or not these were barriers or facilitators, using a coding strategy of -2 for significant barriers to +2 for significant facilitators. And we also then used superscript alphabetical notations for the pathways. And I'm just going to highlight here our training strategies. So we have training modules. You can trace that back to, these are meant to address 2 barriers within the intervention characteristics domain of the complexity of the intervention. Following that through, outcome, right? Our primary outcome here is going to be reach and adoption, which are conceptually related specifically to the ability to train providers to deliver the intervention. And there's lots of different causal pathways that get pretty complicated, which is why we don't have arrows or to use superscripts. But there's a of completed logic models available. Not surprisingly, you will need supporting text and resources to further expand on the elements of the logic model. These can occur in places like in text, potentially in tables, or in figures. And I have a couple of different elements here that you might want to include in addition to the logic model within either a paper or proposal. I'm going to go this, but there are at different stages of research, the logic model can be useful. In planning for a project, it often begins with known parameters, as I kind of mentioned already. A completed logic model, we worked from two bookends where we knew the implementation outcomes that we wanted to achieve, and we also knew the service delivery context. And so we were then able to fill in from there what strategies would be needed and what mechanisms would. We also worked with community partners and stakeholders to fill in the implementation strategies, as well as the other kind of components of the logic model, the strategies in particular. When you actually have a project that's ongoing, a completed logic model can serve as a protocol research project. It also can be used to track what happens, what's altered, and any deviations from the study protocol. Once a study is completed, you can use the logic model for reporting. So you can show what happened during the study, report the communication of findings. And then a kind of more advanced application is to actually use the logic model from a number of different studies that implemented a similar evidence-based program. I'm going to say really quickly that it's a survey after introducing people and having them use the logic model as part of a 2-day training that it achieves pretty high acceptability and feasibility. So some of the key areas I want to show you here is that 2/3 or more rated either moderately or very helpful in terms of the IRLM in improving rigor and reproducibility, serving as a roadmap for their project, clearly reporting and specifying the plan, understanding the connections between the different elements, as well as identifying gaps in the logic of their project. These are all available in the manuscript or in the article that's published. That we provided, which I'm going to show here in a second, were either moderately or very helpful in completing the logic model, and that in general too, that the logic was increased due to the training, which in large part was based on the logic model. So some resources for really gives kind of definitions as well as some basic guidance included in each of the different pieces of the logic model. This is available again in the manuscript and the website. We have a number of worksheets, one that's on implementation outcomes and one that's on strategies to really help you kind of dig into the level of specificity that's needed, kind of jog your memory about what you might want to include. Here is the link to the logic model, the IRLM website that's hosted by the Center for Prevention and Implementation Methodology at Northwestern. We'll make that available for sure to be able to access all of these different resources. Just a note too that if you're not a member, join the Prevention Science and Methodology and Implementation Science. Also an archive of a lot of the best implementation scientists around the country and internationally. And they're past. That's a great resource for implementation science training. And that is the end. I realized that was fast. Thank you for your attention and hopefully.
Yeah, thank you so much. That was excellent. We do have a couple questions. I'm gonna just mention one of them and refer them to the other talk. So one of the questions was, can effectiveness and implementation research happen simultaneously? And the answer is yes. And I would refer you to Jeff Curran's talk. And if you wouldn't mind, Ricky, can you put the link to the site where all of the talks are, that they were recorded, so you can have access to the talks and the slides. Another question, are there guidelines regarding the number of higher level units that are required to undertake randomization?
No, but it always is a consideration of power. So I can think of studies that I've personally been involved in where we had as minimum as 3 units, where we had basically a multiple baseline interrupted time series design that used multi-level modeling. We were still likely a bit underpowered, but we did randomize those 3 different units. It was a federally funded study. That's probably a little bit on the low end. More likely, it's going to be somewhere in the double digits as kind of a minimum. And it really depends on complexity, depends on ICCs, all those kinds of things when you're determining power.
Great. Would you consider different facets of culture as different contexts and determinants? For example, gender and religion, different gender roles often have different health outcomes, and gender roles are often prescribed, dictated by faith beliefs.
Sure. So it really depends on who you're talking about in terms of these different gender roles and things like that. One of the things that is admittedly a bit of a deficiency within a lot of implementation science frameworks, and this is it's not included in the consolidated framework for implementation research, which is the most commonly used determinant framework, is really some of these patient level variables. If you're talking about the actual like gender, religion, faith, things like that of providers and of service delivery agents, yes, those are very commonly assessed and often fall under kind of the characteristics of individuals within the CIRCL model. And we do find this, I think, from my example of pre-exposure prophylaxis, we do see that there is differences in people's religiosity from a provider side about whether or not they're comfortable talking about and prescribing something that is related to risky sexual behavior and the prevention of HIV. So that is certainly something that does get incorporated into what kinds of implementation strategies would be used. We often do things like try to reduce stigmatization. We try to normalize behaviors. We try to just purely educate people about those kinds of behaviors to address some of these issues. But I think if you're talking more about patient level, it's something that does get considered, but probably needs a little bit more attention.
Sorry, I was on mute. And I have a question or comment, probably both. In implementation mapping, we've described the use of logic models for planning implementation strategies. And here you talk about it in terms of planning your research. And I'm wondering if you've also used, or if others are also starting to use these logic models for planning the strategies that they're going to use in the first place, particularly since you list out the determinants and the mechanisms of influence and things like that.
Yeah, so I think actually in our published paper on the logic model, we referenced your work actually on this, and basically said that there are additional steps potentially that could be used. One of them is implementation mapping for strategy selection, which then you would use the results of that to populate the implementation research logic model. We've also used, actually, we recently completed this and we're trying to get a paper out. We used the adapted ERIC process that was developed by Tom Waltz and Byron Powell, which is basically a Delphi process for the selection of implementation strategies. And we then use that to populate the implementation research logic model. So there's definitely kind of some complementary or adjunctive either methods or just tools that people have developed that I think really are nice complements to the logic model, or at least can help to populate that appropriately. That's a great point, Rita.
And then last question, what is the role of cultural differences in determining external validity in implementation research?
Great question. This is an area that's getting a lot of attention right now, mostly around kind of the general health disparities and health inequities lens. And this has been one critique, honestly, of implementation research, is that we sometimes do unfortunately test implementation strategies in communities that don't experience inequities, or we try to generalize strategies that worked for the majority of people, but maybe didn't actually work for the health and equity community to all. And so there has been a push over the last few years, and I think it's really even picking up steam right now, to more effectively look at how we conduct implementation research with communities of color and with under-resourced healthcare systems in particular, to try to address some of these disparities. We actually just got funding from a NHLBI consortium that has to do explicitly with eliminating healthcare disparities and heart, lung, blood, and sleep disorders, where we are doing exactly that, which is specifically looking at a community that experiences disparities in cardiovascular health and seeing what kinds of implementation strategies need to be used with that group that potentially don't generalize. And that we argued successfully, since we got funded, that is an appropriate and useful way to do implementation research, because generalizability is not always the end goal, or should not necessarily be the end goal.
That's great. Well, we're out of time. Thank you so much, everyone. Ricky, I'm going to turn it over to you to close us out here.
Yeah, thank you everyone so much for attending today. Thank you, Dr. Smith, for a wonderful presentation. The slides and the recording will be posted on our website by the end of the week. You'll get an email about it, but it's also in the chat box. And we really appreciate all your time over the course of this conference series.
Thanks, everybody. Thanks so much, JD. It was awesome.
Yeah, thank you. Appreciate the opportunity.
Bye, everyone.